think we're live on Instagram. Give me a second here. There we go. All right, guys. Let's see. It's 8:59. Give me a minute here. Let's see if everybody else can tag on and join along. We'll start right at 9 o'clock. So officially live though here on both platforms. It looks like. All right, guys. It is 9 a.m. It is Friday. It is Fitness Athlete Friday. And this is the PT on Ice Daily Show. I'll be your host today. My name is Joe Hanisko, Dr. Joe Hanisko. I'm a physical therapist actually up in Michigan, Grand Rapids, Michigan area. So it's west side of the state. I'm just an hour or two, not even probably, away from Mitch and Allen over in Fenton. I am part of the clinical management of fitness athlete team. Maybe a new face to some of you guys. It's the first time on the podcast here live with everybody. Not my first podcast, but the first one that I'm directing, so it should be a good time for all of us here. So let's hope that it goes well. We're going to be talking about exercise-induced headaches today, or as the literature would kind of state them, primary exertional headaches. So that's going to be the topic. The plan is to kind of talk about what they are, how we might treat them, what they look like in comparison to other headaches, and then I threw a couple of case studies in just for some clinical relevance too that we can discuss as we go into it. But before I dive into anything too deep, I want to list off a couple of the ICE courses that we have coming up. I tried to pick out a few of them at the end or beginning of November 7th and 8th, I think it is, over in Cherry Hill, New Jersey. We have a clinical management fitness athlete live course. I think our foundations class, our online CMFA foundations class, goes live at the beginning of November as well. I think that's November 9th, so right after that weekend. If I remember correctly, Modern Management Older Adult has an online course coming up as well at the end of October. So those are good courses to look for in the near future. I threw down here Total Spine Thrust, the 21st and 22nd over in Wisconsin. And then that is next month, November 21st and 22nd. And then over in December, Modern Management Older Adults goes live in Ohio as well too. So quite frankly, guys, I was just scanning through the page again, our PT on Ice website. We have a bunch of content coming out. People are putting a ton of work in right now with COVID. I think everything got pushed back. So if you're looking for a course, either live or online, there's going to be something out there for you. So head over to the website, check them out, and see what you can find. They're all fantastic content, so I'd highly advise taking a look at those there. So we are going to be talking about headaches today, guys. And I think, frankly, before I started, I wanted to just begin with sort of the fact that headaches can come from multiple sources. And as a growing primary care profession as physical therapy, I think that's what we should all be shooting for, is the people to seek out for a number of different issues. But I think it's our due diligence that, especially with these unique circumstances like headaches, that we do a good job ruling in or ruling out with red flags, yellow flags, and things like that as well. Headaches can be driven from cervical spine, can be neurologic components, it can be hormonal based. So there's so many different epicenters of where these headaches might be derived from. So getting through a good thorough history after our symptom behavior model is ideal. So some of the red flags that I'm looking for treating headache specific patients, I'm diving through, going back to the baselines of PT school, looking at upper motor neuron issues, reflex base, the Bavinski's, all that stuff that can be tied to our central nervous system. Just a quick screen, either through question or through assessment. Cranial nerves, you're talking vision, smell, balance, vestibular issues. Those can all be tied in potentially to headaches as well. I'm asking for or looking for unusual, clumsiness or losses of balance, things that are different or changing for this patient. Blood pressure is one that jumps to the top of my head quite quickly as well. I think, our profession has really pushed for doing blood pressure screens on a lot of our patients, and the headache population should definitely be one of those that sits at the top of your list that you're doing for screening as well there too. So I guess the last big one that I'd probably be diving into is trauma. cervical based traumas, motor vehicle accidents or injuries to sports related stuff. That can be big too there. So there's numbers of red flag symptoms that we can look for. Really the point of this discussion here at the start of this was just to say, I think if we really want to build our rapport as a primary care specialist, we need to do a good job at vetting which patients belong to us or belong to somebody else. So do a good thorough job there. So let's get into good stuff though. So I chose this topic, frankly, for somewhat of a selfish reason, I would say. About a year and a half ago, I was put to my knees by headaches for the first time in my life, and they were very specific to when I was working out. It's a big part of my life to be in the gym. I'm an avid CrossFit athlete, and I was to the point where this started one day, and for a couple of weeks I was like toast. I couldn't even get back in. I couldn't stay moving, and it was the first time I had experienced something like that. And so I had to kind of figure out what it was, and luckily I have a good colleague close to home here who I see co-treat with. Is a mentor of mine. She was able to help me out a little bit, but that got the gears spinning when it's happened to me. I was like, this is insane. It really wiped me out. And then since then, I've probably treated 3 to 4, maybe 5 patients specifically that had very much so headaches that were induced through fitness and exercise related activity. So I kind of got my gears going, dived into the literature a little bit, which we'll find out later maybe isn't as helpful or isn't as specific as we'd like it to be. But I thought it was a worthwhile topic there. So I think that as a profession that is so well-rounded in physical therapy, being able to treat headaches is crucial. I think, I've had so many patients who have come to see me for headaches eventually, and I was not the first option, second option, sometimes, third option. But hopefully that starts to change. But in order to do that, we got to be effective at understanding different types of headaches, how they present, how to help people through them. So I thought this would just be a good adjunct to, some of the stuff that ICE has already covered with Jordan, Barry, and Jeff and the spine crew with the cervicogenic related headaches and TMJ issues potentially as well. So we'll dive into a little bit more about the exercise-induced headaches or primary exertional headache. So that's sort of the literature term, PEH, primary exertional headache. So it sort of alludes to the idea that exertion brings these headaches on. Obviously today's Fitness Athlete Friday, so we're going to be speaking mostly to how fitness and exercise can induce these headaches. But I guess I would go without saying that exertion of any kind can potentially be a problem when these are the source of your headaches. So we're looking at things as simple as, running up a flight of stairs. It could be a trigger to just basic ADL activities for some people, depending on the amount of exertion they're putting into it. So there's a lot of literature out there too on the IADL activity that we're probably all thinking about, late night activity stuff. So it's a real deal. I've had patients talk to me about that as well too. So sex can sometimes produce these headaches as well. I guess that truly can be exertional as well. So that's the main common trigger that we're seeing with these, obviously, which sort of differentiates these, and hence the term primary exertional headaches. I kind of realized that after diving into the literature about headaches, when they use that term primary, they sort of clump that into its own category there. So even though that is the case, I think as I talk a little bit more with you guys here, I think it's great for differential diagnosis purposes to have clusters that we can look at to help us sort of sift our way through. But ultimately, I'm starting to find that maybe there's more of a relationship between these exercise headaches and other types of headaches as well too. So in terms of etiology or the pathophysiology, again, this is where the literature really states that it's more of a idiopathic onset, unknown causes necessarily, not exactly sure what this is. A lot of thoughts about it being potentially, cardiovascular, demand increase. So some of the vascular tissue in the cranial region could be a portion of it. I've seen some literature on just even increased inner abdominal or thoracic pressure. So, for example, doing a heavy back squat, big belly brace, building up some of that Valsalva pressure. Essentially, I think the mechanics there would be that the increased abdominal pressure almost seals off some of the return blood flow and even cerebral spinal fluid flow in the head, which can sometimes create cranial pressures that could be triggering to headaches as well too. So those are those are sort of the thoughts, but I don't think there's anything concrete, at least from the literature I was reading. I was diving into a lot of the big sources of, neurologic conditions and headache treatments, and reading different articles, and nothing was really conclusive. So in terms of headaches, they're, somewhere between, I was reading, 8 to 15% of headaches could be potentially linked to these increased demands, these exertional based headaches. So common, maybe not super common, but I think at some point, especially as we start to reach our expansions out into the healthcare world, you're going to bump into these there. Treatment wise, they pretty much lump this into a self-limiting kind of condition, which essentially would be they didn't have any fantastic options for treatment. Over-the-counter meds, prescription-based headache medications were sometimes talked about. I think, as with a lot of medications, the efficacy of that is 50-50, sometimes at best. So frankly, that's just not a good enough answer. I don't think that 50-50 is where we want to be. I think we want to be tipping that scale the opposite direction, and I think that's where our profession needs to kind of step in big there. So differential diagnosis with these is where I think I started using more of my clinical assessment to kind of figure out what it truly meant to me. So as I mentioned before, I think it's great that we cluster these into their own categories, like migraine headaches and cervicogenic musculoskeletal based headaches, and then tension headaches, or the primary exertional headaches. Like, they're great to be clustered, but I think with my experience now, I'm starting to figure out, since I've treated a handful of these and been reading on them, as I started diving into assessments with my patients, the cervicogenic components were almost always consistent with people who had these primary exertional headaches. So I think the one factor that would allow it to still live in its own world over there is that they were almost always triggered, or they should be triggered, by increased demands on the body, where sometimes tension-based or cervicogenic-based headaches, they don't need to be triggered by that. They may be also triggered by exercise, but they also have other possible triggers as well too. So just diving through the literature, though, there wasn't a whole lot on how to assess people with these situations. A lot of the literature I was reading was more medical based, and I just didn't find a bunch on, either physical therapy or chiropractic care, for example, who might be assessing the spine more. So that's sort of where I started diving into this, and I found that was definitely a big part of it, there's no doubt. And I still don't think I have a concrete answer on what it might be, other than the fact that if you just think about even the importance of our cervical stabilizers with any movement. I mean, there's research and EMG studies out there showing that if we look at some of those suboccipital and posterior cervical muscles, with just the anticipation of movement, like eye movement even, it'll trigger contraction or co-contraction of that musculature back there. So I think that it's more than reasonable to expect that exercise is obviously challenging those stabilizers as well, and that may be a portion of what we're dealing with there. So let's get into the good stuff, though. I want to dive into a couple of case studies. I'm for sure going to hit one. We'll look at the time. I'm trying to keep you guys less than 20 minutes for sure. I like to talk, and sometimes that gets me in trouble. So I figured I'd start with my case study. Honestly, it was just the most, the one that hits home most with me. I remember it very much in detail. I have another one of a young girl I was treating recently, younger, meaning in her early 20s, a college student. But for me specifically, at the time that I had these, I was 28 years old, training CrossFit 5-6 days a week. No prior history of headaches, really. Nothing that would lead me to having these. These were out of the blue, just smoked me. I remember the day. I don't remember the exact workout because I didn't get through it, to be honest, but started out with an 800-meter buy and run, went fine, and it went into wall balls. And I hate wall balls as it is. If anybody knows me personally, I got to throw that ball like 40 feet in the air, I feel like, every time. So never looking forward to them, but we had them. And I got like 4 or 5 reps in, heads cocked back, started feeling a little bit of pressure. So I dropped the ball, just thinking it was just like a kink in my neck kind of thing. Picked the ball back up, started throwing it again, and wham, like they hit me. I felt like just this intense throbbing pain in the back of my head. Dropped the ball again, just thought maybe, again, hadn't had experience, what's going on. Sort of stared off into the distance for a second, and they kind of calmed down, and I gave it one last effort, but I realized very quickly that it just was going to be an absolute no-go there. So I took myself to the assault bike, just thought, let's just stay moving. some on there just lightly pedaling, not really using it as a workout. But even that increase of intensity of being on the assault bike at just low RPMs was enough to bring that headache back on fairly intensely, to the point that I was down and out on the floor for probably 10-15 minutes, just slowly letting those symptoms decrease. So I thought it was a freak event. I went back to the gym the next day and basically spot on first minute or two of movement. It was even just in the warm up this time, and we were doing some sort of bounding, skipping warm up. It was a run day for us again. I think it was in the summer. We run a lot. And I was done. I was out, and I realized that something was going on. Wasn't quite sure. This is when I then joined up with my colleague and mentor friend Stephanie, who started working and treating with me. But here at ICE, we use that symptom behavior model for this case study. I kind of want to go through that as well too. So if I was looking at myself, location of the pain for me was back of the head, occiput area. Super intense, very throbby pain. I would even describe it as lancinating. So similar to a tension headache from, I've had them in my past, very rarely, but I had them, and obviously treated that a lot, but it was intense. Pain scale for me during exercise in those first 2 days, enough to make me stop. I threw a 7 out of 10 on that scale up there. And it built up relatively quickly for me. I'm talking a minute or so, especially after that first bout on that first day. That second day was about a minute worth of movement and I was done. They tended to resolve fairly quickly though, and would get back to a baseline of 0 essentially. I had no pain at rest. And from my aggravating factors of increased intensity exercise to my easing factor of just rest, it was 10 minutes usually, 10, 12 minutes maybe. So quickly to build on, quickly to come off for me, but absolutely intense during that factor there. So in terms of actual assessment, very, very, I guess range of motion wise, we'll say, just active range of motion for me, clean, clear, flexion, extension, side bending, whatnot, full range. No provoking symptoms with it. Joint assessment though, Stephanie was moving OA, AA, upper cervical spine, very tight, very restricted. Maybe not uncommon for me, but noticeable, I would say, and definitely noteworthy. Very inflamed almost, to the touch. I had actually never felt anything as irritating. I mean, obviously I was dealing with the pain, but I was palpating back of those cervical extensors, and it was just hot and bothered back there, which was unusual. So that's where that cervical component started to draw my attention. So I had the exercise component, but there's definitely the cervical component coming in there. So very point tender to the back of the head. Negative to all special testing though. So I guess except for cervical flexion and rotation test, I think Jeff had posted a video on this. I use it a lot for upper cervical mobility testing. But tucked me into full flexion and tested my rotation. It was a little bit limited there, but otherwise special testing, spurlings and compression, all that, no radicular symptoms, nothing there. So really it came down to just a lot of soft tissue irritation in the back of my neck there. So symptom behavior model, check that off the board. Assessment, we check that off the board. Going to treatment. That first week, Stephanie, I probably saw her twice in the first 7 to 10 days. Her hands-on manual therapy skills are fantastic, and she did upper cervical mobility stuff, some cervical manipulation for me. She ended with dry needling, and maybe here's where we didn't walk the walk the way that we should have, but I had her throw the whole kitchen sink at me because I was just I gotta get rid of this. So probably not the best approach to it, but dry needle, SCM, cervical extensor, suboccipital tissue, and it definitely helped. I had tried to work out again that week. The symptoms came back on relatively quickly, but not quite as intense, I would say. So we knew we were on to something here. We started working on a little bit of isometrics for my cervical spine, so I was doing a lot of chin tucks. I was doing just even throughout the day, just some handheld cervical isometrics. Do some banded isometrics for the cervical spine. Started throwing in some upper thoracic work as well too. So I attacked a lot of that cervical thoracic junction and cervical spine area there with a lot of the isometric and strength training stuff. And it was a good start, but definitely didn't take my symptoms away. I was unable to, more than just an easy bike, I was unable to exercise at that point. Week 2, we continued the same manual care. But I started to realize that I think it was less about specific exercise and more about reintroduction of exercise at this point. So I really dove into a real specific and graded warm-up, and I used it as fitness, honestly. I broke a lot of things into Imam Tabata style stuff, even where I was doing I could handle walking, I could handle biking at this point. So now I started adding bounding back in. So I was doing a lot of like the dynamic warm up stuff, and I was even doing some single unders there to promote some dynamic control and stability work for the cervical spine. And I would use it on like a pain scale too, where if I started approaching like that 4, 5, 6 level on my pain scale, I backed off. And generally using like a Tabata style for me was great because I could work on it and rest, work on it and rest. And I gradually increased the demands of that over that week, and it was helpful. But I still wasn't back to CrossFit stuff or even weightlifting. I did have pain one time trying back squat, and I just called it quits after that too. So I'd say week 1 was like no go for fitness. Week 2, dynamic warm up for fitness, which was part of my I would say my plan of care. And by week 2.5 is when I started to reintroduce some of this stuff. And I was a little hesitant about anything cervical related. I pretty much eliminated that for 2 weeks. I'm talking heavy cervical stuff like wall balls or handstand push-ups. But we were approaching actually in the open, the CrossFit Open, and there was the glorified Diane workout, which was 21, 15, 9 deadlifts at 225, handstand push-ups, my wheelhouse. And then it was additional work of heavy deads and handstand walks. So I slowly tested those out on the day that I was going to do it and got up to doing like 10 in my warm-up. And I was like, I think I'm going to go for it. And luckily I did. And at that point, that's 2.5, almost 3 weeks out from the original onset. I got through that workout and it was pretty much pain-free. So I think whatever I did to work up to that point with the graded exposure and the cervical work, the isometric work, some upper thoracic work really seemed to tone down my symptoms. And I saw like daily or every couple of day improvement on what I was able to tolerate there. And so 2.5, 3 weeks out, fully resolved, haven't had the issue since. So for time's sake, I'm going to leave it with just that first case study, guys. Sorry, I am long-winded. I had another one with a runner. I will tell you, it looked very similar. She had a little bit longer history of headaches prior, but now they were very specific, induced headaches with exercise. Her cervical assessment was a little bit more restricted than mine in general, thoracic more restricted. And again, the key with this was the graded warm-up that I used and essentially the modified fitness program that I used to get her back to working out. I mean, ultimately, that's the tough part about these is that exercise is often a common way that we treat headaches, but when exercise is the problem, we got to figure out how we can go about doing that there. So let me just quickly review then. We'll get you guys off. We're at 20 minutes now. So these primary exertional headaches truly are their own entity, but I think that there's definitely a heavy crossing pattern between the cervical component, the cervicogenic related headaches and these exercise induced headaches. So think about how they combine together. Think about how they're separate, but definitely treat them with close proximity for sure. We need to consider all conditions when dealing with headaches. That's where a great history and the symptom behavior model will help you with that. Don't be afraid to ask the questions that you think aren't worth asking, because a lot of times they truly are. And if not, the worst case scenario, you get a solid no and you move on and you do your job the way you're supposed to anyways there. So get a good history, good medical history, and I think you'll be all set there. In terms of treatment, if we're talking about specifics, I found that isometrics were very good at decreasing intensity, helping with pain modulation. So use them early on, use them often, use them to modify how they're feeling. But I think the key and the skill for us as physical therapists will then come in with how creative and how willing you are to understand what their goal is in fitness, how you can get them back to doing that, and how you can use that as their actual plan of care there. So if you got the runner, you start out with, encouraging them to stay walking at the very least. Maybe you build intensity down the road, cardiovascular intensity by adding in biking, but the skill there is that maybe biking is less of a cervical demand than the pounding of running. And then you go into a lot of run walk interval stuff where I think you can start to increase over time your work ratio, decreased your rest ratio, and hopefully you lead these people to success down the road. So we got a lot that we can bring to the table, guys, and hopefully this was a good transition of thought for you with treating headaches there. So drop comments in, tag me, Joe Hanisco, find me on Facebook. Thoughts, if you want to continue to talk about it, let me know how we did. But enjoy your Friday, guys. I'm heading out to Denver after later today to meet up with Zach and Megan, Zach Long. We got a live course out in Denver there, so hopefully I talk to you guys soon. Have a good day. Bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.